Hello everyone, my name is Gwen Driscoll. I'm the Director of Communications and Publications at the UCLA Center for Health Policy Research, and it is my pleasure to welcome you to the Center's Health Policy Seminar Series. This monthly series, as many of you know, features the leading experts in the field of health and health policy, discussing issues ranging from asthma, diabetes, and obesity to healthcare coverage, and especially this year, healthcare reform. You can learn all about our upcoming seminars at our website, which is www.healthpolicy.ucla.edu. And you can also learn about them by subscribing to our popular e-newsletter, Health Policy News, also findable on our website. I'm delighted to introduce this month's speaker, Dr. Dylan Roby, who will talk to us today about the safety net, and specifically county roles in healthcare within the broader context of healthcare reform. Dr. Roby is the director of the Center's Health Economics and Evaluation Research Program, which examines the economic and financial impacts of national, state, and local level healthcare interventions. Dr. Roby currently leads a number of center projects, including one to facilitate the low-income health program's transition into Medi-Cal. This is funded by the Blue Shield of California Foundation and the Department of Healthcare Services. When not leading a statewide evaluation program for the center or providing official healthcare reform estimates to the state, Dr. Roby is also an assistant professor in the UCLA Fielding School of Public Health, where he teaches American political institutions and introduction to health services, and guest lectures frequently on Medicaid, Medicare, and the Affordable Care Act. Previously, he also worked at the George Washington University Center for Health Services, Research and Policy. It's my great pleasure to introduce Dr. Dylan Roby.
Thanks, Gwen. Hi, everyone at home, watching from home, and in the audience. So today we're going to talk a bit about, I wanted to get away from the Affordable Care Act, even though it's almost impossible to do so, but talk a little bit about a window into what's going to happen in the counties in the state of California post-Affordable Care Act, and looking at how the changes that are going on in terms of Medicaid waivers and the state's position in terms of implementing health reform could potentially change how counties operate, how counties provide care to the uninsured, and how they finance that care. So today I wanted to talk a bit about the currently uninsured, opportunities and challenges presented and faced by the counties, county efforts to provide health care, and compare a little bit about what's going on now, what's gone on in the past, and what we might expect from counties going forward as our uninsured population hopefully shrinks because of the expansion of Medi-Cal, the expansion of Covered California, and what we can expect to occur in the counties as they change this role, as enroll from completely, a payer and provider to possibly a provider getting reimbursed for uninsured care, or previously uninsured care. And talk a bit about the new expectations and roles for counties, how that was dealt with in the state budget deal that was made a few months ago. Also looking at the remaining uninsured and what to expect as counties contribute to the healthcare system in a different fashion than we're used to. So first I wanted to touch a bit on the currently uninsured. And in this case, many of you are familiar with the California Health Interview Survey data, which in the newest iteration showing 2011-12, among the non-elderly population, we can still see pre-Affordable Care Act, a year before the ACA is really implemented, that about 17% of the population is continuing to be uninsured, about 5.4 million people, 52% of the non-elderly population getting coverage through employer-based care, and also about 22% of the population in Medicaid and the Healthy Families Program being transitioned into Medi-Cal. So it's important to note that we still have this large uninsured burden, even though it's diminished since the last version of CHIS, where we were in the middle of an economic downturn, but also that we can expect to see growth in both Medi-Cal as well as the individually purchased population because of the fact that Medicaid is expanding, likely to result in about 1 to 1.4 million people getting new access to care through Medicaid, and then about 1.7 to 2 million people by 2019 estimated to get coverage through Covered California or individual market purchase coverage. Now, it's also important to note that in addition to this, or not in addition to, but supplementing this 5.4 million people who are uninsured currently when the survey is asked in any point in the year, we also have quite a few people who are uninsured for at least part of the year. So there are almost 7 million Californians, almost 21% of the population, have at least some break in coverage. And I want to talk about that in terms of the continuum around county indigent coverage for the uninsured, the Medi-Cal program, and Covered California, which should mitigate some of these breaks that people see in coverage over time and could kind of change the game in terms of reimbursement during those breaks. So next I wanted to focus a bit on opportunities and challenges that are faced by the county or that the county may benefit from. In terms of unprecedented opportunities, the Affordable Care Act is a fairly comprehensive piece of legislation. Although we're focusing, most media coverage right now is focusing on this tiny little swath of the population that probably represents about 3% of the entire population that might be having to change insurance coverage. For the most part, the law is really going to impact a broad group of people, probably about 10 to 15% of our population, by providing them with better access to insurance coverage. Now, of course, the undocumented, the non-lawfully present population will be excluded from both the Medicaid Expansion, or Medi-Cal here in California, and the Covered California subsidies, but we'll still benefit in California from about 1.8 to 2.7 million people qualifying for coverage who were previously uninsured. So there will be lots of movement within programs where people who were in the individual market before might take advantage of subsidies in Covered California to buy insurance, but they're not going to be newly insured. We have about almost 2 million people, even at the lowest estimates, that will be actually given insurance for the first time or provided with access to insurance for the first time versus their pre-ACA status. One big part of this population is potentially the almost 600,000 people who are currently in the low-income health program who will be automatically transitioned into Medi-Cal as of January 1st, 2014, as part of a bridge to reform waiver that was used from 2011 to now to manage this population, expand Medicaid early using county dollars, and then hand them off seamlessly to the Medi-Cal program into managed care plans. We'll also see safety net providers that are going to have to kind of negotiate how they work within these circumstances, but they're likely to increase revenue from these previously uninsured populations or previously indigent populations who are enrolled in somewhat county-organized indigent care programs, who will now have reimbursement following them from federal dollars, either through Covered California or through Medi-Cal. Now remember that for this newly eligible population, they will be subject to 100% federal matching from 2014 to 2016 as part of the Affordable Care Act. So right now, in the low-income health program, because it's part of a Medicaid waiver, the counties are putting up the state share of the funding, about 50%. The federal government is paying the other 50%. But once these people transition into Medi-Cal starting in 2014, all of a sudden the federal government is paying the entire bill for the first 3 years, and they'll be paying 90% of that bill in perpetuity after 2020 when the matching rate phases down. In addition to that, of course, we have the Welfare and Institutions Code here in California, which basically says in Section 17,000 that there's an obligation to counties to provide their residents, their lawfully present residents or citizens who are indigent or low-income uninsured, access to care. And counties do this quite a bit differently. They've kind of interpreted the law and responded differently over the years, usually with clarification issued by court decision rather than actual statute. But counties have, they have these homegrown programs that have been created over the years that have then been, part of them have given way to the low-income health program with a more organized benefit package, a more organized structure for receiving care. And so that will change substantially. But to give you an idea of how much they vary, 4 out of the 58 county programs that deal with the indigent under Section 17,000 obligations cover people over 300% of federal poverty level, like those in San Francisco and Ventura and Santa Clara. There are 9 of the 58 counties that actually provide care to the undocumented, 8 of them being public hospital counties, 1 of them being a non-public hospital provider county. So you have quite a bit of variation in terms of how the counties provide this obligation and meet their Section 17,000 requirements to be this provider of last resort at the county level. But that game will change quite substantially because of the fact that the majority of the low-income, uninsured eligible, lawfully present residents of a county will now have access to care through Medi-Cal and Covered California, or through their employer, or possibly buying in the individual market without subsidies. So the role of the county in meeting that Section 17,000 obligation might change. The county safety net could shrink or contract, or it could be asked to address new issues that come up because of an existing remaining uninsured population that we'll see even after the Affordable Care Act. So in terms of, I know those opportunities seem like challenges, but here are the actual challenges. So county-based providers will need to start competing for patients in Medi-Cal and Covered California. As most of you know, Covered California is completely contracted with private plans. Medi-Cal is completely contracting with private plans. There really won't be much Medi-Cal fee-for-service, especially for this newly eligible population. And so the county is now going to have to be in, each county will potentially have to decide as providers, if they own their own clinics, if they own their own hospital, whether to engage as contracted providers in a managed care setting, or to potentially work with a local initiative plan, or to develop those partnerships to try to maintain their existing uninsured patient population now in this new phase of being a paying insured patient population, with an insurance plan now governing what kind of care they receive, what networks they have access to, rather than the county having that power as they've had before. In addition, the counties, especially those in areas with public hospitals or university hospitals, will see quite a bit of a reduction in disproportionate share hospital payments, which are subsidies provided by the federal government through Medicare and Medicaid to compensate hospitals that do lots of uninsured care and lots of Medicaid. And the ACA, with the idea being that we're going to transition all these people from uninsurance and low-paying Medicaid into insurance and possibly better paying, or at least more systematically delivered Medicaid, that the need for those disproportionate share hospital payments now dries up substantially. And the law actually cuts them almost in half over a 10-year period of time. So if these county obligations for users shrink, if the disproportionate share payments shrink, will these populations be replaced by new groups? Will all of this demand that has been provided, or all the supply that's been provided through county systems, where they're handing off patients to Medi-Cal managed care networks, they no longer have to worry about really significant episodic care, will it now be replaced by a new group of people who were previously not able to get care and now can actually seek out care? So there's this concern from some public hospital folks, as well as county leaders, that think that as the currently uninsured population transitions into insurance, that they will be replaced by a new uninsured population, typically one that might be undocumented or won't buy insurance, and therefore there'll still be this unfunded group that will create a new burden to the county that's just different than the current one. The other thing that will be occurring in the counties is the fact that the state, as part of the deal to expand Medicaid in California under the Medi-Cal expansion, is requiring realignment of county funds that since 1982 and then 1991 had been embedded at the county level and had been kind of going up over the years to deal with the indigent, are now being reclaimed and put back into paying for the potential shortfall that the state could suffer from expanding Medi-Cal. As of 2017 and on, the state's going to have to pony up part of the matching funds, the state share for this Medi-Cal population. Even though it's small, it's about 5 to 10% until 2020, and then after 2020 it'll be 10%. The state was still concerned about the financial repercussions, and also a concern that by expanding Medi-Cal in a more seamless way, by now using modified adjusted gross income to qualify people who had previously been in Medi-Cal already, that there would be new, or eligible for Medi-Cal already, that there would be this new woodwork effect of people who are signing up for Medi-Cal who were previously eligible. And those people do not carry with them 100% federal matching under the Affordable Care Act. They only carry with them 50% federal matching. So the state was concerned about that, and as part of the budget deal, they outlined two methods for reclaiming or retrenching some of the money that they had been providing to counties. And two of those options are basically a 60-40 split, where the county that was delivering indigent care would just hand back 60% of the funds that they had been getting back to the state, and that would be used to plug other holes in the state budget and pay for that loss of the of the uninsured population. The other option is that it would be an 80-20 cost-sharing split or savings split, but that the counties would actually show the state how much they spent in cost for the uninsured population, how much they're getting in revenue from the newly eligible Medi-Cal covered California population and all other third-party payers, and they would calculate what the savings was that needed to be given back to the state. So we'll talk a bit about that more later, but it's a choice that counties will face, and they'll have to decide which one to use. But it's not that the counties are getting to keep all of the resources they already have to provide indigent care that are supplied by the state. They're going to have to give a significant portion of it back, and in some cases 80 to 90% of that money. So to touch on those briefly, the disproportionate share funding, to give some detail, really is represented mostly by about $1.1 billion in disproportionate share payments made to California each year out of federal dollars, out of about $11.5 billion nationally. So we represent about 10% of the DISH pool nationwide, and most of it is concentrated in 20 public and university acute care facilities owned by counties and then owned by the University of California system. So the ACA will require a reduction about 49% by 2019. So in 2014, the federal budget included a $500 million reduction with the idea that there would be some enrollment in the Affordable Care Act and that people would be moving from uninsured into Medicaid or uninsured into covered California, but the entire need for the safety net wouldn't be gone because we expect this to be a phased-in approach to getting new access to insurance. But by 2019, about $6.5 billion would be taken away from the DISH program, and with the idea that we would be fully implemented with Affordable Care Act insurance standards by 2019. Now, you'll note that the $6.5 billion is not 49% of $11.5 billion. This is federal math where the disproportionate share payments continue to grow over time. So by 2019, based on what we would have expected disproportionate share payments to be, you then subtract 49% of that, and that's where you come up with the $6.5 billion. Regardless, it's going to cut the program in half, even though the growth in the program will still continue based on the typical Congressional Budget Office and federal guidelines. So states, with the way that the disproportionate share regulation is worded, it encourages the targeting of funds to hospitals that deliver lots of care to uninsured and Medicaid individuals with a specific focus on Medicaid. However, states kind of have to divvy up this pool, and the federal government does so based on a formula, and that formula will still encourage or at least not penalize. It may not encourage, but it will not penalize states that have high uninsured rates because they don't implement the Medicaid expansion. So it's possible that states that don't implement the Medicaid expansion could be getting a large share of DISH funding as long as they target that DISH funding to uninsured care and Medicaid care rather than spreading it out to lots of different hospitals. And this has been an issue over the years because states will use their disproportionate share money to compensate private sector hospitals that don't do lots of uncompensated care and leave the public hospitals very vulnerable. So a lot of the money will be going away for the DISH program, and depending on how the state actually does the calculation and gives money to each of the counties or each of the public hospitals residing within the counties, some counties could benefit and others could not, depending on how that formula is used. And then on the county realignment side, about $300 million has already been shifted in 2013-2014 fiscal year. So this last budget, that was just a deal made, as part of the Medicaid expansion process. But then next fiscal year, the counties will have to choose whether this applicable formula, the 60-40 split or the 80-20 split, based on the reconciliation of the actual cost of care with a cap on spending based on historical data versus the new revenues collected through third-party payment, will be a better deal for them. So it's expected that most of the counties that do not have a public hospital will use the 60-40 split, where they're just going to hand back 60% of all of their funds for indigent care and make do with the remaining 40%. And the 35 county consortia that's called CMSP, the California Medical Services Program, has basically already agreed in statute to do it that way. So they're going to be giving up. They're currently running, I think, a program, including the low-income health program, about $225 million, and that'll be, they'll have about $35 million left in future fiscal years to pay for the rest of their indigent care program, which will be fairly limited. On the public hospital side, they get to choose whether they want to do a 60-40 split or an 80-20. Most counties are likely to do the 80-20 because they want to actually itemize the actual cost of care and show the revenues collected, because the counties are going to have to become a provider in this new world that's actually getting paid for a lot of the services they deliver through Medicaid managed care products, and so it's probably better for them to track that information and be able to calculate exactly how much each year that they net and pass that savings back to the state. The law also creates a county healthcare funding resolution committee that allows for counties each year to go to this committee and say it was calculated incorrectly, or we would like to change the way the formula is done. So there is a process for making sure that the counties are trued up in terms of their spending and revenue to make sure that they're getting a fair amount of money according to the Medicaid expansion statute. So they have some level of protection, but it's still somewhat unknown in terms of how counties will respond to this and what they will do with their county indigent programs going forward. So I want to talk a bit about county efforts to provide health care and rewind a bit to think about how they did things in the past and why they're doing things the way they are. So in terms of caring for the uninsured, which is the low-income, uninsured indigent population, it goes back to 1982 when a restructuring of Medi-Cal basically got rid of adult Medi-Cal for childless adult populations and moved the existing Section 17,000 obligation, the Section 17,000 obligated dates back to, I think, 1933 or so, but because there was no funding coming with this childless adult population, this change to Medi-Cal in 1982 really threw the doors open to childless adults using county systems and needing and basically requiring those counties to figure out a way to pay for that care. So there was some funding allocated based on the previous Medi-Cal spending. And then in 1991, these realignment funds were made available for the counties, but that haven't been growing that much, and so it's kind of constrained the county's ability to deliver really robust benefits. Instead, what they've typically done is very episodic care. People are getting signed up in emergency rooms, in clinics when they need something, rather than being enrolled into an organized health insurance program like we would like them to see. So you end up with a very fragmented system, lots of people getting care through emergency rooms, through community clinics, not having good access to specialty care, often having preventable hospitalizations and avoidable emergency room visits delivered and paid for when they could have possibly been averted. So the counties really vary in their approach and eligibility for the programs. As I mentioned, it depends on whether the county has their own hospital-owned or contracted providers. So I believe there are 12 different counties that have their own public hospital. So they have this inpatient supplier that's already in existence, and it's, I suppose, easier to administer an indigent care program in that way, but at the same time it exposes them to lots of risk because they have to take anybody in because of EMTALA, because they end up being this magnet for the uninsured. There are other counties, there are about 5 counties that operate in more of a payer category where they don't actually own any clinics, they don't own any hospitals, but they contract directly with clinics and hospitals that are private sector hospitals like federally qualified health centers, individual private physicians, etc., and hospitals themselves to make sure that there's a big enough network that's willing to accept reimbursement for this indigent population, that the needs are met under the Welfare and Institutions Code. Again, this doesn't mean that they're getting anything close to insurance coverage, but they are getting some level of access, and probably the most important thing is that the hospitals are getting paid for delivering uncompensated care, whereas they wouldn't be if this program didn't exist. The covered services and coordination vary quite a bit. Some counties have innovated, but a lot of that has occurred in the last few years. Also, income thresholds and assets vary quite a bit, and residency requirements vary quite a bit. So as I mentioned, 49 of the 58 counties in the state don't actually provide full benefits to the undocumented population. 9 counties do. So in some counties, even though we consider this the safety net for the uninsured residents of a county, the lawfully present residents are included, but the unlawfully present are not. And so undocumented immigrants wouldn't have much access to care through the actual county system. However, if they were in a payer county like Orange County, where the Orange County Healthcare Agency doesn't actually deliver any actual services, but they contract out with clinics and hospital providers to do it, then a patient could show up who's undocumented at the hospital, at the ER, or at a community clinic, and the hospital or ER would have to basically deal with them from an uncompensated care standpoint. They wouldn't be able to get any reimbursement from the county for their care. But if somebody who was documented did the same thing, they would actually be able to get reimbursed from the county for their care. So quite a few of these, we often think about the counties will be where the undocumented go, but in actuality, in many cases, because very few counties cover the undocumented, even though they're going to be going to county healthcare providers or safety net providers within a county, those providers may not be getting reimbursed because they don't qualify for that Section 17,000 obligation. So that all started changing a little bit, not related to the undocumented, but just in terms of the episodic nature of indigent care, started changing a bit because of a pilot program or demonstration program in 2007 to 2010 called the Healthcare Coverage Initiative, which was part of a safety net care financing waiver done in California. And that basically allocated up to $540 million in matching funds that allowed counties, 10 counties that decided to enroll patients in an organized health system that provide them with a medical home. They had to cover people up to 200% of federal poverty level. They had to provide a standard benefit package, but the standard varied between the counties. So the county had to actually provide a benefit package, have an adequate network. And that previous waiver gave start and kind of set the stage for Medi-Cal's current waiver, which is the Bridge to Reform waiver, which we've been hearing a lot about. It includes both the low-income health program, which is the sequel to the Healthcare Coverage Initiative program that was started in 2007, but it also includes the DSRIP program, the Delivery System Reform Incentive Pool, which is for public hospitals to improve patient safety, quality improvement, develop infrastructure around improving care. And it also includes the transition of people from into managed care from fee-for-service who are seniors and persons with disability, and the California Children's Services pilots. So the waiver is much broader than simply the low-income health program, but the low-income health program, at least right now, seems to be the most important part of that waiver, simply because the transition is occurring where people who were in the low-income health program will be moved into the Medi-Cal program as of January 1, 2014. So the Bridge to Reform waiver through the low-income health program was designed to enroll about 500,000 people in all 58 counties. The guidelines are flexible, so there are two components of the waiver. One is the Medicaid Coverage Expansion part, the MCE population, which is anybody who is under or equal to 133% of the federal poverty level, kind of mirroring the expected eligibility threshold under the Affordable Care Act. This waiver was signed in November of 2010, a few months after the ACA was signed, and so the Centers for Medicare and Medicaid Services were interested in giving California a waiver, but also making sure they had this new population moving into Medi-Cal and not duplicating efforts or wasting money on a population that should be covered under the Affordable Care Act. So part of that deal was to make sure that this population would get care for those 2.5 years from July 2011 to December 2013, when the LIHP program would actually sunset and those people would be moved into Medi-Cal in 2014. In addition, counties had the option of choosing a healthcare coverage initiative that would be, or opting into a healthcare coverage initiative that would allow people over 133% of federal poverty level up to 200% of federal poverty level into, again, an organized program, but maybe not the same type of program in terms of benefit structure and Medicaid requirements that the MCE population was moved into. So in both of these programs, more than 886,000 people have been enrolled since July of 2011. So it's a pretty large number of individuals that took part in the program and maybe disenrolled, maybe lost eligibility, maybe got a new job and got employer-based insurance, or they started when they're 64, turned 65, and now they're in Medicare and duly eligible for Medi-Cal. So there are quite a few people who touched the program, but there are about 600,000 people who are in these two programs currently that will be transitioned as of January 1st. So again, like the HCCI, the LIHP provides a medical home. It provides a more robust benefit package because the federal government viewed the MCE portion of the program as equivalent to Medicaid. So you needed to provide HIV/AIDS care, you need to provide mental health care, Counties had the option of providing substance use disorder benefits. Only 5 did so. And there had to be an adequate network of primary care specialists and hospitals, mirroring what we see in Knox-Keene, the same requirements that HMOs are required to meet in delivering care and being licensed. So to give you a sense of the Medi-Cal expansion population and the LIHP, so there, in the MCE program currently, there are about 587,000 enrollees as of June 2013, which is the last current data set that was reported to UCLA as the evaluator of the program. So it's important to keep in mind, though, that there are 53 counties participating in the low-income health program, so 5 counties decided not to. Those are Fresno, Merced, San Luis Obispo, Santa Barbara, and Stanislaus, representing about 142,000 potentially eligible uninsured adults in those areas. But for the most part, every other county participated, but you can see that they had flexibility in terms of where they set their eligibility threshold. So for the CMSP group, which is a consortium of 35 different counties, they set their eligibility at 100% of federal poverty level. So out of the 149,000 people that are likely to be eligible who are actually uninsured currently in just 2011-12, up to 138% of FPL, CMSP has already enrolled about 62,000 of those people who will be transitioned over. In other counties like Sacramento, they went up to 67% of FPL. You'll notice with the stars that in Kern, Monterey, Placer, San Francisco, Santa Clara, they all started at a lower FPL level and recently upgraded to 133% of FPL level because they wanted to enroll as many new people as possible and make it an easier transition into Medi-Cal in 2014. So even though you might see that they have relatively low enrollment versus where they should be, we might expect that to change quite significantly because most of them expanded after June of 2013 when this data was supplied. Now, to give you a sense of the size of the covered California eligibles in the low-income health programs, there are about 24,500 enrollees as of June 2013 as well. Only 4 counties actually opted to include and use the Healthcare Coverage Initiative program to enroll people going up to 200% of federal poverty level. So you can see that the transition to covered California will really be felt in Alameda, Contra Costa, Orange, and Ventura, and not many of the other counties. There are kind of certain counties, like San Francisco, for example, that has a couple hundred existing enrollees that earn over 133% of federal poverty level because they were members of the old Healthcare Coverage Initiative program, and they were required to grandfather them into the new program. But most of the counties decided not to engage in this larger expansion and go all the way up to 200% of FPL. So the transition will be occurring over the next few months. It's ongoing. And the enrollees up to 133% of federal poverty level will being administratively moved into the Medi-Cal managed care plans that are available in their counties. So in essence, each of these individuals who are currently enrolled will be getting a letter or have already gotten a letter showing them what choice of plans they have, with the idea that they would maintain their existing medical home. So the low-income health programs already created a medical home model. They already assigned all their patients to a medical home. And now, as part of the transition, they don't want to break that continuity. So the idea being that each individual who's currently enrolled there will be an attempt to link them to their current medical home. And so they'll get a letter saying, your medical home is available in the following 2 networks. So if you don't do anything, you're still going to get the same medical home you've been enrolled in the LIHP, and you could be automatically assigned into one or the other network, and it won't matter. In other cases, they might get a letter that says there's only one network in your county available that will take you into Medi-Cal managed care that has your low-income health program medical home in it. So if you don't do anything, you'll move directly into that plan. If you want to change plans, if you want to change providers, you're allowed to. So you would call the typical healthcare options number and decide to change and opt into a different plan. The states are also very dedicated to focusing on continuity and figuring out how to deal with the complex conditions of HIV/AIDS, mental health and substance use disorders, the homeless population, and initial health assessments and dealing with ongoing treatment that's needed for cancer care, other types of things, to make sure that not only is this an access program and really funneling people over to the correct Medi-Cal managed care plan, but also that the continuity of care isn't compromised by moving people administratively into a new insurance system. For the higher income group, that over 133% of FPL group, they'll be referred to Covered California. They'll be outreached by Covered California representatives in addition to a letter. But of course, you can envision that with the LIHP transition for the MCE population, that Medi-Cal expansion population, they've gone through documentation status. They've checked eligibility based on income. They've made sure that they've been living in the U.S. for more than 5 years, as is necessary for federal law to get federal matching funds. And that case has basically been settled. They've been determined as eligible. When you come to the Covered California aspect, the person is not doesn't only have to be eligible to be moved over. They also have to decide, yes, I'm going to take this private plan. I'm going to sign up for this network. I'm willing to pay a portion of my money into a premium and accept this advanced premium tax credit to help subsidize my coverage. So they couldn't just move them over. The idea was that they would make sure outreach was done to give these almost 25,000 people the ability to sign up for Covered California, know what their options were, but that there couldn't be any automatic way of doing that because of the fact that they would have to commit to actually paying the bill, right? So if you sign up December 15th, you have to pay your first premium by December 25th in order for coverage to take effect. And if you're just administratively moving people, you can't necessarily guarantee that would happen. So the hope is that take-up will be fairly good among this population in interest of maintaining continuity and maintaining insurance coverage, but it'll be up to Covered California to actually do that outreach and make sure people sign up and know what their options are. So I did want to underscore that the consequences of the LIHP expansion go far beyond simply access to care, right? So the federal matching fund, so the waiver basically allows for every dollar put up by the county to result in to result in 50 cents coming back to the county to provide care for the uninsured populations that meet these requirements. So the counties that were previously basically running on half of that budget or even less were able to invest money in medical home assignment, in health information technology, in reimbursement for these uninsured patients, increasing the reimbursement level in some cases from what their existing indigent care program paid to physicians to what their low-income health program could pay. They developed the ability to do care coordination for frequent flyers who come to the ER a lot or need lots of care, the chronically ill. And they also developed these broader networks of providers and relationships that hadn't existed in the safety net in many cases before. I mean, if you go back to 2007 when the HCCI started, there were counties where the public hospital literally did not talk to the federally qualified health center down the street, and all of a sudden they had an ability to share in this new county program to coordinate care and to at least engage in a fair reimbursement mechanism. So it did improve the county's abilities to take on these newly insured patients. So I think if the waiver hadn't happened, we would still be expanding Medi-Cal. We may not be expecting as many people to be signed up on day one. We may not expect 587,000 to just be directly ported over on day one. But there would certainly be concerns about the pending healthcare needs of this population, the network, the state of the safety net, whether they could handle it. And I think California's counties, at least the 53 that participated, certainly have shown their ability to kind of operate like a coordinated system and prepare this population for the transition. So I think that's good news from the California perspective, not only for Medicaid spending, but also for the counties being able to further use the lessons learned in meeting needs of the the existing uninsured population that may not sign up. I'll put in a plug though. So we recently released a report on November 5th called Safety Net Delivery System Redesign, and authored by Nadi Parad and several of us on the Low-Income Health Program Evaluation Team. And we'll be doing a webinar the week of November 21st to discuss the findings of that. So I urge those of you who are interested in learning about what happened in the counties specifically and what counties did what and kind of the lessons learned there, please take a look at the report and also tune into that webinar as well. So now on to the new expectations and roles of the counties. So I think it's important to note that the county roles after the ACI are likely to be somewhat different, right? So we already talked about the fact that they now will be asked to be providers for the insured population. So the counties with public hospitals and clinics will now have to adapt to actually not having an uninsured patient walk through the door, but having somebody with a Medi-Cal card walk through the door or a insurance card from Covered California walk through the door and be able to bill for those services, be able to contract for those services so they don't have to turn that patient away because they're out of network. In addition, the county has developed these kind of private sector networks in a way where people started talking to each other. We had, in Orange County, they had a medical director that was actively intervening with physicians who were prescribing drugs with black box warnings and getting them to change the way they practiced and change the way they delivered medication. So I think we've seen lots of quality improvement and continuity that will have been built into the county systems that won't necessarily go away simply because the funding goes away, especially if that funding is replaced with new reimbursement and incentives to keep costs down in the Medi-Cal population in covered California because of the way contracts are structured. But they will see this continued responsibility to continue providing remaining uninsured with care and/or assistance. So their role will change to identifying and enrolling ACLA eligible individuals into the coverage option that they should have, whether it be Medi-Cal or covered California through no wrong door enrollment, through county eligibility workers in clinics, through community organizations, etc. But they're now going to be asked to operate indigent care programs on a more limited budget because of the realignment funds. They're going to be asked to potentially deal with the undocumented uninsured, even though most of those counties aren't actually providing care to the undocumented uninsured. And they'll still have certain requirements and certain expectations. So in the Medi-Cal expansion, a lot of behavioral health still falls on specialty mental health plans that are delivering care through county systems. And so their care will be integrated between behavioral health and medical physical health issues within Medi-Cal managed care a little bit differently than it might have been integrated within the low-income health program, because they're both covering similar benefits, but the players now end up being different in some cases or the same in others. So to give you a sense of the remaining uninsured population, I want to touch a little bit on findings from the California Simulation of Insurance Markets model, CalSIM, which is developed here and at UC Berkeley with the Center for Labor Research and Education. And we've done this with funding from the California Endowment in Covered California. And we use two different scenarios to model the impact of the ACA on California. A base scenario where it's kind of the typical California implementation where we have lower response to public insurance. We have a longer take-up scenario. People are less likely to sign up. Then an enhanced scenario where it looks a little bit more like Massachusetts with a faster enhancement and take-up and kind of the potentially optimal scenario. So you can see that in 2019, we expect that quite a few people will gain insurance coverage. Without the ACA in 2019, we anticipated about 5.8 million people uninsured at a point in time, with between 3.1 and 4 million being uninsured once 2019 hits. So this includes those 1.8 to 2.7 million people moving from uninsurance into insurance coverage, but also people shifting around and possibly people with employer-based insurance or individual insurance not taking up coverage in the new market because of price differences and employer decisions. The subsidized exchange is expected to have about 1.7 to 2.1 million people. We expect the individual market to have about 2 million people, and Medi-Cal to grow by about 1 to 1.4 million people in the base and enhanced scenarios. But the remaining uninsured are still going to be a significant issue. You can see here that the remaining uninsured, whether you're looking at the 3 million or 4 million number under the enhanced or base scenario, between 37 and 49% of them are actually eligible for exchange subsidies or Medi-Cal, but just decide not to take them according to our modeling results. So it'll be important to not assume that everybody who's remaining uninsured is undocumented or isn't entitled to these benefits or isn't entitled to exchange subsidies, but there are actually going to be people out there that don't sign up for coverage because of some other reason, and awareness will be an issue, making sure that people are aware of the different options available to them and get into the programs that they're entitled to. Now, in terms of the safety net, we looked at, this is a table just of those who are remaining uninsured at or below 200% of the federal poverty level. So I would say about 98% of patients in public hospitals and community clinics tend to report incomes under 200% of FPL. This tends to be the core group that indigent care programs support. And there are about 2.29 million out of the 4 million in the base scenario that would be remaining uninsured under that FPL level. But you can see that a vast majority of them are eligible for Medi-Cal or eligible for the exchange with subsidies because of their income for the most part. And so reaching these 1.4 million people will be important, but also those 1.4 million will be those very likely to stay in county systems, to use community health centers, to use public hospital clinics. So the county being able to take on that new population make sure they're in managed care contracts and are getting fairly reimbursed for those will be important as well. The majority of the remaining insured are predicted to be Latino as well, which underscores the need for not only to target those lower income folks, but also do more, culturally competent and language focused recruiting and inclusion into Affordable Care Act coverage options. And of course, as we typically would know, that most of the problem will lie in Southern California. So really, Orange, Riverside, San Bernardino, and LA probably will represent almost 2/3 of the uninsured population remaining in the state after 2014 up through 2019. You can see the tiny swath from the Bay Area through Placer to the Nevada border. They will have a very low uninsurance rate. We're expecting high response there, but the biggest problem will be in those 4 counties that represent Southern California, with remaining uninsured. Part of these are people who are undocumented, of course, but many of them are low-income working folks who actually are eligible for coverage expansions but just don't take advantage of it. So the future of county indigent programs will differ depending on the remaining uninsured population in their county, right? So in the Bay Area, maybe the needs might be slightly different than that in Southern California. In Southern California, you would hope those counties are actually accepting undocumented immigrants because that may be a very large part of the remaining uninsured population. In LA, that might be true, but in San Diego, for example, or Orange, undocumented immigrants aren't included in their county indigent care programs, and they're basically just going for point-of-service care and resulting in uncompensated care done by private hospitals and clinics rather than having any reimbursement issued on their behalf by the county. So there might be 2 models for these pending, county indigent programs. They're already dealing with disproportionate share funding going down. They're dealing with the county realignment dollars. But there are a couple things that happened in the budget deal that would protect counties slightly. One is that counties from 2014 to 2016 with a public hospital, those public hospitals are able to get reimbursed 100% of cost for the newly eligible Medi-Cal population when they're using services. So they're kind of guaranteed a healthy reimbursement rate in those first 3 years when the federal funding is good, and then I guess that continuation will depend on whether or not we end up with another Medicaid waiver in the future to continue the Bridge to Reform waiver. The other thing that happened is that the Medi-Cal expansion statute specifically states that after the low-income health program population is transitioned, any remaining newly eligible population should be the county clinics and county-owned hospitals should get preferential medical home assignment. So each of the plans will have to assign 75% of the newly eligible population into county-based clinics and hospital settings in 2014 through 2016, and then I believe in end of 2016 to 2017, that requirement goes away and it's 50%. So the counties kind of protected themselves in these negotiations to make sure that they would get medical home assignment from Medi-Cal managed care plans, and also to protect the reimbursement that they would get in the first 3 years. The other thing that could happen in counties is reduction of services, benefits, and capacity by the different county systems. So LA, Alameda, San Francisco, Santa Clara, San Mateo have all signaled that they're going to be kind of keeping their low-income health program. They're going to try to continue enrolling people in low-income health program medical homes, but it's now going to be something that's provided simply by county money and not by federal money. There won't be any matching funds coming through a waiver anymore because it's a different population. But other counties have signaled that they're going to have to cut back services. They're going to have to drop mental health and dental and other things like that. I think CMSP recently voted to reduce their redetermination period from 6 months to 3 months. So you'll see maybe income eligibility changes. You might see more efforts to redetermine people more regularly, but also reducing the actual benefits and maybe not having the same type of comprehensive benefit package that the LIHP guarantees, but something that looks more like what we saw pre-waiver. There's one possibility, though, that of course that the emergency Medi-Cal program, which currently possibly can pay for coverage for undocumented immigrants who meet the current eligibility threshold but are simply undocumented, is now expanding to a certain extent, in that anyone who is eligible under the new rules, if they don't meet the eligibility expansion requirement because of being undocumented, would still be qualified for emergency Medi-Cal, and so hospitals could still be reimbursed for these very quick episodic cases, even though they're not entitled to full insurance products. So in general, I think we can assume that new coverage options will generally improve access for most Californians. I think that's important. I know I pointed out lots of limitations and struggles that counties would have to face, but I think the bottom line is still that more than 2.5 million people will be getting new insurance as of 2014 through 2019, using lots of federal money to pay for it. It's not money that's costing the state much, and so we should be somewhat content with that, in that counties, they're not having to change how they operate because funding was slashed in half or any dire circumstances occurred. They're being asked to change how they do business and being asked to respond to a new population because they now have more insured patients coming through their doors rather than having to kind of wade through the uninsured, uncompensated care morass that they've been dealing with for the past 30 years or so. But we should revisit the effectiveness of the LIHP transition. We should look at the response to the Medicaid expansion, the remaining county safety net funding, and this realignment funding within the next 2 to 3 years, and possibly continue to follow that, because I think we may see some counties benefit more than others, and there should be some look into how we're spending our money, and as we move toward payment reform and trying to efficiently allocate funds and figure out how counties fit into this overall coverage puzzle in California, I think it'll be important to look at what's actually going on in those existing safety net programs. But these differences have always existed in the counties because of politics, because of resource allocation, because of the population demographics. So I think we can still anticipate that counties will vary quite a bit in how they deal with their Section 17,000 obligation, but that it's not all a negative story. They have lots of opportunities to take advantage of the new investment due to the Affordable Care Act and continue to rely on that investment that was made in the low-income health programs. But they still need to remember that there are these vulnerable populations, including the undocumented, that need to be taken care of, who are going to be remaining uninsured in both the state and the county and the country as a whole. And so a robust safety net will still be important. So making sure that counties still have an allocation, disproportionate share, hospital payments don't completely go away, that federally qualified health centers can still continue to get cost-related reimbursement and deliver care in an efficient, effective way will be really important to making sure that even though somebody may be residually uninsured and not able to take advantage of the Medicaid expansion, that they still are getting at least some level of care that meets their needs. So with that, I will wrap up and take questions. Yes.
So, Dylan, early on, you mentioned that county facilities are now going to have to compete for patients. I'm not sure that we've discussed this before, but it occurred to me that rather than being a hypothetical, we should actually know at this point, shouldn't we, whether our county facilities part of the networks in the plans that are being offered on the exchange. I know that there have been problems having the list of provider networks available on Covered California, but this should actually be a knowable at this point, whether or not county clinics have been signed up to be part of those networks.
Right.
Dylan, could you repeat the question for the benefit of
Sure. So the question was, do we know at this point for the Medi-Cal or for the county providers, the county hospitals, county clinics, are they actually contracting with exchange plans at this point? The medical group and hospital lists have been pulled down and put up multiple times. My understanding is that they're still somewhat spotty and the medical group and hospital information isn't completely correct at this point. However, I think it's fair to assume that in most counties, the county hospitals are probably contracted with the lower cost plans in the networks. And this is probably encouraged by the fact that a lot of the plans that came out with pricing came out with fairly low pricing. So they were actively negotiating with providers to make sure they're willing to take a rate that's probably lower than you typically would take as a private physician or private provider. And so a lot of, in LA, for example, the HealthNet product, the Molina product, and the LA Care product is probably very likely to have some county clinics or at least safety net providers in it. LA Care probably has a very significant county clinic orientation, whereas HealthNet might have quite a few federally qualified health centers. And if you go to other areas, so if you end up in San Mateo or something, San Mateo Health Plan, which is the Medi-Cal managed care plan, didn't actually engage in exchange negotiations. They're not a plan in the Bay Area. So you're then relying on Kaiser, Anthem, Blue Shield, Chinese Community, and those networks may not have decided to contract because there wasn't this pre-existing relationship. We know that San Mateo Health Plan has a very good relationship because of their Medi-Cal managed care plan status and the fact that they're the third-party administrator for the low-income health program, that they're delivering lots of care through the county facilities. But since they're not an exchange product, maybe we'll see less of that type of overlap in those areas. So I think it really depends on the county, but I think we have every reason to believe most safety net providers are trying to get into exchange networks, at least one, because they're willing to take a fairly, low reimbursement rate in many cases, and they know they have to respond to newly insured patients, and they don't want to be the only ones taking care of the uninsured, residually uninsured.
So for the LIHP counties, if the county safety net provider didn't sign up with the health plans, these LIHP members will lose connection with the current providers, right?
That's correct. So if a county provider is not in any of the Medi-Cal managed care networks that exist at the time of the notification letters, the letters would go out saying, there are these plans in your area, none of them have your medical home in them. So you're going to have to, if you don't do anything, you'll be assigned to a medical home based on where you live, the language you speak, and our typical kind of quality and availability based algorithm to selecting a plan, and then the plan will put you into medical home. So you have choice to select a plan among the 2 to 5 different plans you might have in your area, and then decide on a provider. Each month, the beneficiary in Medi-Cal can actually change their plan. So they don't have to settle for one plan for the whole year. If they don't like the plan they signed up for in January, by February they could be in a new plan, and they could also be in a different provider as well. I'm pretty sure that they can change provider as long as the health plan will allow it. So you're correct that there could be the low-income health program, as they move over, could potentially be delinked from their existing Medi-Cal or their existing medical home and put into a new Medi-Cal managed care contracted medical home primary care physician. And then they would have to potentially talk to their provider and say, hey, I'd really like to keep you as my doctor. Are you going to be participating in any networks? And once that provider decided to opt into a contracted network, they could switch back pretty easily. Yes,
I have another question.
Yeah.
I have actually lots of questions, but we're not going to have time for them all.
We have a meeting
you
at
and I can
2:30.
talk
So.
later. But for the rest of the audience, so you mentioned that you didn't want to focus on ACA, but as you know, one of the big issues, and I've noticed that the federal government now has released enrollment figures nationwide, and they're quite low. But yesterday there was sort of pre-release of information saying that nationwide, only about an estimated 400,000 people had signed up for Medi-Cal or Medicaid nationally. And yet we know from the LIHP program that in a sense there are about 525 to 550,000 people in California in a sense pre-enrolled. Do you have any idea why that number is falling through the cracks in these national estimates? I mean, is there any reason why California isn't making sure that those numbers are out there more publicly, and as a result, they seem to be not tallied as part of the national counts?
Right. Yeah. I mean, I think they are. So the question was, currently, federal figures show that in the states that expand in Medicaid, about 400,000 people have already signed up, typically through the state or federal exchange. And why isn't the 600,000 number showing up in that count from California for the low-income health program transition? I'm not sure why that's happening. I'm assuming it's because of the way they're, like the data run they're doing at that point in time, where none of these people have effectively transitioned. They actually effectively don't transition until January 1. They are still in existing programs in the low-income health program in that specific category until December 31st. and people can still sign up in the low-income health program. So if you go on Covered California and you click on the link that says, I need help now, it says, well, you may be eligible for a low-income health program in the future, right now, and we will transition you over in 2014. So I'm assuming that number is kind of falling through the cracks, because if the state was to pull this data right now, none of those people would pop up as a new Medi-Cal enrollee. They would pop up as a low-income health program enrollee, and we just know that they're being transitioned over. So I would just say it's a fair enough guess to just add the 587,000 people to that tally, and you can claim credit for identifying 1 million people who have qualified for Medi-Cal.
I think we need to write a letter to the secretary.
Possibly. Sue?
So when you were talking about the LIHP program, that there were several counties that didn't participate in it, and I was curious about two things. One is why they didn't participate, and what happens to the transition for people in those counties.
Right. So, I mean, for the most part, the reason to not participate tended to be county dollars. So you have to remember that they're not getting the same matching rate that the new Medi-Cal population will get. They're not getting 100%. The county is putting up the state share, and then the federal matching comes in much later. And they have to basically invoice for it to the federal government and show that they spent all this money. So often you're dealing with 6 months to a year of delay in terms of getting the funds back to the county. So the county has to front all this money, and so in Fresno and Merced and those other counties that didn't participate, I can anticipate that the county supervisor said, well, we have X amount of money for our indigent care program, and you're telling me I need to spend all this money right now. We need to do a better benefit package. We have to enroll people through county supervisor or the county system. We have to start collecting documentation status. We have to do all of these things to meet these needs to make them look like a Medi-Cal population, and then we're going to get paid back much later down the road, and we have to spend twice as much money. So in order to do that, to get it back. So, I can see why that would be a concern, and counties don't have a ton of money sitting around to spend on indigent care. If they did, I think you'd see more expanded indigent care programs. So I think that the cost was the main concern, and actually, so I mentioned that quite a few counties decided to shift from their existing kind of lower income threshold. Like San Francisco is at 25% of federal poverty level until April, I think. And when the transition was coming up, they said, okay, we're going to expand to 133% of federal poverty level. So they only have to spend money on that new population for 6 more months or 8 more months, however long the person was enrolled. And there are quite a few counties that said, we don't have the ability to do that because we've already exhausted the county budget that we had set aside for running our program, so we can't expand to 133. Even though we're going to get matching funds for it, we're still spending half of the money. So that was a concern as well.
Just to add to that, it's probably also the level of funds required for the administrative, all of the infrastructure that had to be in place in order to run a program like the ones that some
Right.
counties have spent a lot of money.
Right. So for the webinar folks, the comment made was that the administrative burden in developing infrastructure to actually deliver and run the program is quite significant as well and would cost money. And I think you also have to envision that, that's money they've kind of put together these county programs over the years on a shoestring with a very limited budget, and expanding them to look like Medi-Cal is very difficult. One of the big issues that came up in July, back when the low-income health program was getting implemented, was that CMS, the Centers for Medicare and Medicaid Services, was basically going to treat this like Medi-Cal, and so these programs now had to deliver mental health services, HIV/AIDS services that had previously been carved out or not carved out, but had been handed off, and the responsibility had fallen with the county behavioral health system or Ryan White programs, and all of a sudden they had to pay for it. So that's when you saw San Francisco and other counties cut their eligibility level because they didn't have the money for this, potentially risky bet on taking care of all these HIV/AIDS patients and dealing with high-cost antiretrovirals and that type of thing. Yes. All right. Thanks very much.